about drugs in pregnancy and lactation. One question, we'll try to start from the basic. If a drug cross the placenta, can we give that in pregnancy? No, you are wrong. The answer is not always no. Remember, almost 99.9% drugs can cross placenta. There are two main drugs. One is heparin, second is insulin. They do not cross placenta at all. Other drugs may cross the placenta, maybe lesser, maybe more. Okay? So that means even if a drug cross the placenta, it reach the baby, still we can use in pregnancy if the drug is not causing any harm to the baby. So that means if a drug is safe, it reaches the baby but do not cause any harm, so we can use. So read very carefully the statement. If a drug cross the placenta, it does not necessarily means it is contraindicated in pregnancy. Okay? So the drugs which cross the placenta are not necessarily, but if they cause malformation in the baby, then they will be contraindicated. And the drugs which cause malformation in the baby, they are known as teratogenic drugs. So obviously teratogenic drugs are contraindicated in pregnancy. All drugs are not contraindicated. Teratogenic drugs are contraindicated in pregnancy. Okay? Now this teratogenic effect of the drug, it depends upon many factors. The two major things you need to remember. First, in which trimester we are giving. Most of the organogenesis occurs in the first trimester. So if a drug is producing teratogenic effect in first trimester, it can cause gross congenital malformations. Okay? So the first trimester is the most dangerous period. Okay? Second thing, this teratogenic effect will depend upon dose of a drug, as well as it will depend upon how many duration we have given, how long we have given the drug. So the longer we give the treatment, the higher the chances of teratogenicity. Okay? Now, if a drug is teratogenic, we should not give. So which are the important drugs which we should give in pregnancy? Which are the important drugs which we should not give in pregnancy? So for the entrance exam point of view, the important ones which you should be aware of, like first of all, anti-hypertensive drug if we talk about. Among the anti-hypertensive drugs, the drug of choice, or we can say the safest drug in pregnancy, the drug of choice is labetalol. It is antihypertensive drug of choice in pregnancy. Labetalol is drug of choice both in routine hypertension in pregnancy as well as in hypertensive emergencies in pregnancy. So only the route will be different. For routine hypertension, we give orally. For emergencies, we give intravenously. So labetalol is safe. Another very important drug which is safe is methyl dopa. You must be aware about these two drugs. Methyl dopa is a drug of choice according to JNC guidelines, but labetalol is nowadays preferred. Okay. Now, which antihypertensive drugs should not be given in pregnancy? And the must to remember are AC inhibitors and angiotensin receptor blockers. These are totally contraindicated in pregnancy. AC inhibitors and ARBs should not be given. Labetalol, methyl dopa are safe, but AC inhibitors and ARBs are totally contraindicated. So that is number one. Antihypertensive drugs which are safe in pregnancy. Then second is anti-thyroid drugs. Now among the anti-thyroid drug, the important thing to remember, propylthiouracil. It crosses the placenta much lesser as compared to carbimazole. Crosses the placenta lesser. So because of that reason, propylthiouracil, it is a drug of choice for hyperthyroidism in first trimester of pregnancy. In first trimester, because maximum organogenesis is occurring during this phase. But PTU has many other disadvantages, like it need to be given 3 times a day. It can cause liver damage in the female. So because of the other disadvantages, we do not prefer PTU anywhere else apart from first trimester. So if second or third trimester is asked, then antithyroid drug of choice is carbimazole. In first trimester it is PTU, in second or third trimester it is carbimazole. Although the question should mention which trimester they are asking, like drug of choice for hyperthyroidism in first trimester of pregnancy. But if they do not mention the trimester, they simply ask drug of choice for hyperthyroidism in pregnancy. Okay? So I will always prefer the answer as PTU, because whenever they ask the question like this, which is drug of choice in pregnancy, so means they want to ask which is safest in pregnancy in terms of teratogenicity. Clear? So I will always prefer the answer to be propyl thiouracil, although trimester wise in first trimester it is PTU, second and third it is carbimazole. But if they ask in pregnancy, that means they are asking the most dangerous period, that means first trimester. Clear? So my answer will be propyl thiouracil. Then coming to anti-epileptic drugs in pregnancy. Here is the problem. Almost all anti-epileptic drugs are teratogenic. Some are less, some are more, but all are teratogenic. Highest teratogenic drug is valproate, whereas lowest teratogenic drug are levetiracetam and lamotrigine. So from the name itself you can remember, valproate is very much teratogenic. The teratogenicity risk is around 7 to 8%, whereas levetiracetam and lamotrigine, they are least teratogenic, minimum teratogen. But problem is, there are two important type of questions which can be asked. The first one is, a female is taking an anti-epileptic drug, she is well controlled, now she become pregnant. So what advice will you give to her? The most important thing to remember here, the most important thing in epilepsy is to control seizures. If a drug has achieved this objective, it should not be changed, even if it is teratogenic. Even if the female is taking valproate, we will not change, because if we want to change the valproate and start other drug, we need to adjust the dose. And during this adjustment period, if one seizure occur, it will be very much harmful not only to the mother but also to the baby. So we are not ready to take that risk. So if there is already some drug which is effective, do not change, continue same. The guidelines say do not change. So we will continue valproate, because the maximum benefit we will get is, normally valproate causes around 7-8%, and lamotrigine etc. they cause 2-3%. So we will get a benefit around 5 to 6%. Remember, even with valproate, there are 92-93% chances that the baby will not suffer malformations. Okay? So what advice we will give is continue valproate or continue that anti-epileptic drug, but two things we will change. The first thing we will change is we will add high dose folic acid. Remember, most of the anti-epileptic drugs are causing neural tube defects, which can be prevented with folic acid. Normally in pregnancy, the dose of folic acid is 400 microgram per day. But if there is high risk pregnancy, like the female is on anti-epileptic drug, the dose is increased to 10 times. That means 4000 microgram per day, or simply 4 milligram per day. Okay? So high dose folic acid is started daily. And second thing, we will advise that you should not miss the regular ultrasounds, because whenever we can detect the malformation, if it occurs, we can abort at the earliest. So these are the two important things. Now there is second situation. A female was not taking anti-epileptic drugs, or the female did not have seizures. She is pregnant, and first time the seizures occur in pregnancy, and we want to start the anti-epileptic drug. So obviously we will start with the safest one. So if the seizures the female is not on anti-epileptic drug, then we will start with levetiracetam or lamotrigine. These are safest drugs. So these are anti-epileptic drugs in pregnancy. Then we have drugs for bipolar disorder in pregnancy. We know normally drug of choice for bipolar disorder is lithium. Lithium is drug of choice for bipolar disorder, but lithium is teratogenic. It can cause Epstein's anomaly, congenital tricuspid atresia. Now, apart from lithium, many other drugs are teratogenic. Like anti-epileptic drugs are the other drugs used in bipolar disorder. Most of them are teratogenic, valproate-like drugs. So the only option which remains in pregnancy are antipsychotic drugs. Both typical as well as atypical antipsychotic drugs, they can be useful in bipolar disorder and they are safe in pregnancy. So bipolar disorder in pregnancy, the drug of choice are antipsychotic drugs. So that is important about the bipolar disorder in pregnancy. Then moving to antimicrobials. Which antimicrobials are safe in pregnancy, which are unsafe in pregnancy? Remember, most of the antimicrobials are harmful in the pregnancy. We know tetracyclines, they affect the growing teeth and bone. We know fluoroquinolones, they can affect the cartilage and tendon of the baby. So many of them, like sulfonamides, can cause connectors in the newborn baby. So most of the antimicrobials we avoid. So you should remember which antimicrobials are safe in pregnancy, and that you can remember from PCM. We know paracetamol is safe in pregnancy. So PCM are safe. So P for penicillins, C for cephalosporins, and M for macrolides. So penicillins, cephalosporins, and macrolides, they are safe in pregnancy. Okay? So these are the important drugs which should know about the safe or unsafe in pregnancy. Now one important point remaining is lactation. A female has delivered a baby, and she has a baby and she is lactating. She is giving her milk to the baby. Now some of the drugs, they can be secreted into the breast milk, and the baby can get that drug and the baby may get the problem. Now important thing, lactation is not a big problem because most of the drugs which are secreted in the breast milk are very small in quantity. Okay? So usually major problem do not occur in the baby. But nevertheless, we should be careful that the baby should not get the drug unnecessarily. So what we mostly advise in a lactation is we should give breast milk to the baby at such a time when the drug is present minimum in the blood of the mother. So when the drug is minimum in the blood means it will be minimum in the breast milk also. So time of lactation and time of milk feeding and time of taking the drug is important. So what we advise is the female should take the drug just at the time of or just after the feeding the baby, because when the female has taken the drug, it will take time to go into plasma, and in the meantime the female feeds the baby. So this time the breast milk will contain minimum quantity of the drug. So now the baby has already been fed. So now the female can take the drug. So minimum chance that it can affect the baby. Okay? So usually we recommend giving the drug in lactation just after or during, just before the